Hello everyone, very good evening. So today we are starting with a 3 hours long pediatrics revision session for the upcoming FMG exam. I know that the session was supposed to be held at 5 p.m. and we are slightly behind on time because of some unfortunate circumstances. But without wasting any further time, let's begin, right? So if the audio and visual is clear, we can go ahead. Okay, so let's start. Okay, let's begin. So first of all, we are going to discuss only those topics which are very, very important for your exam. You cannot afford to miss out on these topics, right? So the first topic that we are going to discuss is the general pediatrics. It includes growth and development and nutrition, right? Majority of the questions that are asked in your FMG exam are from this topic only, and apart from that, some questions from neonatology, right? So without further ado, let's begin. What is growth and what is development? Are they same? In layman terms, we use them synonymously, right? That my baby is growing, my baby is developing. Both of these terms are used synonymously, but they are actually very different. How they are different? Growth means increase in the number of cells, number or size of cells, right? Growth means increase in the number of cells or increase in the size of cells, right? Whereas development means maturation of function of cells. It refers to maturation of function of cells. That means whenever I'm talking about growth, I'm dealing with the quantitative aspect, right? That means either increase in the number or increase in the size, quantity is affected, right? So this is quantitative aspect, quantitative aspect. Whereas development, it is a qualitative aspect, right? And development, it depends upon the CNS maturation, the maturation of our central nervous system, right? It depends upon the CNS maturation, right? So growth में size बढ़ रहा है, number बढ़ रहा है. Development में there is maturation of function, right? Now, let's look at the parameters that we use to assess growth. Growth में क्या हो रहा है? There is increase in the number of cells and size of cells. How we are going to assess this growth? There are some age-dependent parameters and there are some age-independent parameters. What do I mean by age-dependent parameters? That with age, these parameters values would change, right? If I say 3 kg for a newborn, that seems to be okay. But if I say there is a 2-year-old child whose weight is 3 kg, that's definitely not okay, right? Similarly, goes for height. If I say the length of a child is 50 centimeter at birth, that's normal. But if I say the height length of a child is 50 centimeter at 1 year of age or 1.5 years of age, that doesn't seem to be normal, right? So these are age dependent parameters that are dependent upon the age of the individual, right? So these includes weight. These include weight, height, that include weight, height, right? And apart from that, BMI and head circumference, right? These are your age-dependent parameters. What are age-independent parameters? Age-independent means irrespective of the age of the individual, the parameters are going to be the same, right? The yardstick is going to be the same. So these include two, the important ones. These are mid-upper arm circumference and skin fold thickness. We are going to read about them a little more further. SFT is skin fold thickness, right? So now moving on to the trends, moving down to the trends, how the weight is increasing with time, how the length is going to increase with time, right? We all know that at birth, what is the average weight of a child on birth? It's 3 kgs. It's 3 kgs, right? It's 3 kgs. And if the weight is less than 2.5 kg, we label it as a low birth weight child. If the weight is less than 1.5 kg, it is very low birth weight child. If it is less than 1 kg, it is extremely low birth weight child. And there are some images that are given here. These images they ask in your FMG exam. Look at this image, the first image, A, right? Can you name the device? What type of device it is, right? Is it a Salter scale or a beam scale? I use a very funny mnemonic to remember that, right? Can you see the hook here are S-shaped, right? So this scale is known as Salter scale, right? Whereas there is a balancing beam over here, so this is beam scale, right? So these are frequently asked in your exam, these images, right? Image-based question, very simple questions that can make a huge difference in your overall result, right? As we discussed, three categories, low birth weight, very low birth weight, and extremely low birth weight. Apart from that, according to the gestational age, we have certain charts, right? For example, if I have a preterm baby, the weight is definitely going to be less. But is the weight appropriate for that gestational age? How would I get to know? So for that, we have some charts, right? And we refer to those charts at the time of the birth of the child. If the weight of the child is lying below 10th centile, that means the weight of the child is below the 10th centile. That is known as a small baby, small for gestational age baby. On the other hand, if the weight lies above 90th centile, that is a big baby, that is large for gestational age baby. And if the weight is lying in between 10th to 90th centile, it is referred to as appropriate for gestational age baby, right? Now, as soon as the baby is born, the baby does not start gaining weight thereafter, right? Initially, the weight is lost and thereafter, the baby gains the weight, right? So after birth, there is some weight loss. What is this weight loss and why this weight loss is happening? This is nothing but physiological weight loss. And this physiological weight loss happens due to the loss of extracellular fluid. Loss of extracellular fluid. Now the question comes, how much weight loss is considered to be normal? Normally, in a term child, this weight loss can be up to 10%. 10%, right? And this weight loss happens in the initial 7 days of life. Initial 7 days of life, right? There is physiological weight loss that happens initially over the 7 days of life, and the child gains the birth weight by day 10. By day 10, right? So 10% weight loss that is regained by day 10, right? Now, what about preterms? Preterm babies, they have more surface area exposed, right, as compared to their weight. So they have more losses, more extracellular fluid losses. So their weight loss would be also be more. So their weight loss would be approximately up to 15%. And they regain this birth weight by the end of day 14. That is second week of life, right? So you have to remember initially there is what type of weight loss? Physiological weight loss, and that is due to loss of extracellular fluid. This happens in the initial 7 days in a term child, and the birth weight is regained by 10 days, day 10 of life, and in preterm it can go up to 15% and regained by the end of day 14, right? Now coming to a trend which is asked in the exam, that when does the weight doubles, when does the weight triples, 4 times, 5 times. So a very easier trick to remember. Remember that initially the weight is going to increase very fast. So by 5 months of age only, the weight becomes 2 times. By 1 year of age, it becomes 3 times. By 2 years of age, it becomes 4 times. By 3 years of age, it becomes 5 times. By 5 years of age, it becomes 6 times. By 7 years, 7 times. And by 10 years, 10 times. Right? So this is how the weight trend happens. Now, moving to Length or height, that is the second age-dependent parameter. Okay, so at birth, what is the average length of a newborn? First of all, what is length and what is height and how they're different? Length is we make the baby lie down and measure head to toe. That's nothing but your length. And what is height? We make the child stand and then measure from head to toe. That's height. So at what place we are going to use length and at what place we are going to use height? Length we are going to use up till 2 years of age, up till 2 years of age, and height thereafter, after 2 years of age, right? Why we are making this 2 years child lay down and then measure the height or length? Because of the physiological bowing of legs, right? Because of the physiological bowing of legs, if we make this child stand up and measure, we can get a falsely low height, right? Because there is physiological bowing of legs. So we use this device to measure the length. Can anyone tell me what this device is? A device, what is this device? I used this device to measure the length. Yes, this device is nothing but infantometer. Infantometer. You can see in this device, I have a scale below and we have two ends. One end here, it is the fixed end. It is where the head is placed. And the other end is the mobile end, where we move it to oppose the feet of the child, right? So here it would be the foot end of feet of the child would be there, right? And I'm going to use this infantometer to measure the length of the baby till 2 years of age. And why we are doing this? Because of the physiological bowing of legs, right? What about height? What device do I use to measure height? I use this device. What is this device? This is nothing but stadiometer. Stadiometer. You can see this child standing straight, right? And I'm using this scale, pushing it down and measuring the height of this child, right? So this is stadiometer that measure the height. After 2 years, I'm going to measure the height of the child. What is the normal length of a newborn at birth? Can anyone tell me what is the normal length of newborn at birth? At birth? At birth, the normal length of a newborn is 50 centimeters. 50 centimeters. And in first year of life, there is gain of 25 centimeters. Gain of 25 centimeters. Right? So that means at 1 year, what would be the final height of the child? At birth, it was 50 centimeter. In 1 year, there is 25 centimeter gain. So at 1 year of age, it would be 75 centimeter, right? And then thereafter, in the next year, the gain is 10 to 12 centimeter. So add another 10 centimeter to it. So at 2 years of age, it will be 85 centimeter. And finally, at 4 years of age, the height of the child becomes 100 centimeter. Thereafter, there will be a sudden increase in the height, right? Because of the puberty, right? So after 4 years of age till puberty, the height increases 6 centimeter per year. And as soon as the puberty hits, there will be growth spurt, the height will increase. In males, it can be as much as 10 centimeter per year. And in females, it can be as much as 8 centimeter per year, right? 8 centimeter per year. So this is the height or length or trend that we see in normal individuals, right? Now coming to the questions that they ask in the exam. The first question is, when is the height of the baby double of that of the birth, right? What is the height at the birth or length at the birth? We all know it's 50 centimeter. So the question is asking when, at what age, the length or height is double of that of birth. Double means 100 centimeter. And we just read that at 4 years of age, the height is 100 centimeter, right? So the answer here would be 4 years. So if the question is like when the height will double, the answer is going to be 4 years. But if they asked when the weight will double, the answer is going to be 5 months. 5 months, right? Now moving to the next question. This question is asking, when is the height of the child half of the adult height? Half of the adult height. If you look at the average adult height, it is close to 160 centimeter. Half of that would be 80 centimeter, right? And do you remember that at 2 years of age, it's close to 85 centimeter? So the most appropriate answer is here is going to be 1.5 years to 2 years. That is 18 months to 2 years of age. The height is going to be half of the adult height, right? Moving to the next age-dependent parameter, that is head circumference. So how do you measure head circumference? Can you notice this baby here? How we are measuring the head circumference? We are using a tape. We are using a measuring tape, right? And we are placing this tape in a very meticulous way. Posteriorly, it is landing up to the occiput. That is the highest point of the occiput, and anteriorly just above the supraorbital ridge. Just above the supraorbital ridge. Right? And the overlap of the tape is done at the parietal region. And we take 3 such reading, and average of that is going to be the head circumference of the child. What is the normal head circumference of the child at birth? The normal head circumference of a child at birth is 33 to 35 centimeter. 33 to 35 centimeter. And how does the height grow? How does the height grow? What happens in the initial 3 months? The increase in the head circumference is 2 centimeters per month. 2 centimeters per month. That means in these 3 months, what would be the final height gain? 2 into 3, that is 6 centimeter, right? Over the next 3 months, the increase in the head circumference is 1 centimeter per month. So the total gain would be 1 into 3, that is 3 centimeter. And in the next 6 months, the increase is 0.5 centimeter per month. That means 0.5 into 6, which is again 3 centimeter. So can you tell me what is the total increase in the head circumference over the 1 year? 6 plus 3 plus 3, right? That is 12 centimeter. 12 centimeter. So if let's say I take that the head circumference at birth was 34. So after 1 year, what would be the head circumference? I add 12 to that. So it would be 46 centimeter, right? So at the end of 1 year, the head circumference of the child will be close to 46 centimeter, right? After that, in the next year, the gain is close to 2 centimeter. So by the end of 2 year, it would be 48 centimeter. 48 centimeter. Now, what is important for your exam? In exam, they are very fond of asking 2 questions. Question number 1. What percentage of the head size, what percentage of the adult head size is there at birth? If you look at the birth head circumference, it is 33 to 35 centimeter. How much is this of the adult size? It is actually 65 to 70% of the birth size. 65 to 70 centimeter of the birth size, right? So at birth, I know you must have seen a very newborn baby. The head is quite big as compared to the body. Actually, the head size at birth is 65 to 70% of what the size is going to be in the adulthood, right? So it is 65 to 70% of the adult size. And as soon as you reach 2 years of age, this is actually 90% of the adult size. 90% of the adult size. It is very important for your practical knowledge as well. You must have seen various ads out there, right? The Horlicks ad, the growth powders ad, protein powders ad. What do they say? They say that the most of the development of the child happens in the initial 2 years of life, right? So you can see that the head size, the head growth is maximally growing in the first 2 years of life, right? So the neural growth pattern is such that the maximum development happens in the initial 2 years. Now that we are talking about head circumference, there is a very important ratio that we need to discuss. That is the head circumference to chest circumference ratio. right? Head circumference, we know how to measure. We take a measuring tape, place posteriorly over the occiput, anteriorly just above the supraorbital ridge, overlap in the parietal region, and take three such reading and average that out. How do we measure chest circumference? We just again take the measuring tape and measure the circumference of the chest at the level of nipples. That is going to give me the chest circumference of that child. Why this is important? We know at birth, the head size is big as compared to the body. So at birth, my head circumference is going to be more than my chest circumference. And this difference is said to be of 3 centimeters, 3 centimeters, right? As the child grows, the chest would also grow, the body would also grow. At 1 year of age, it is at 1 year of age that head circumference is equal to the chest circumference. And after 1 year, now the chest circumference will outgrow the head circumference, right? And all of us definitely our chest circumference is bigger than the head circumference, right? So this is an important ratio as soon as the head circumference is considered. So we have dealt with most of the age-dependent parameters that are height, weight, and head circumference. Now moving to the important age-independent parameters. Right, in the beginning we discussed two parameters, that is mid-upper arm circumference and skin fold thickness. Important one for your exam is this mid-upper arm circumference. How you're going to measure the mid-upper arm circumference? How do you know that this is the middle of the arm? We take two bony points. What are those bony points? Above, it is the acromion process. And below, it is the olecranon process. Right? We mark these bony points, and draw a line joining these 2 points. Make a line joining these 2 points. At the middle of this line is the place where we are going to measure the mid-upper arm circumference, right? Why this is an age-independent parameter? It is said that in between 6 months to 5 years of age, what happens? This mid-upper arm circumference, it stays constant. It stays constant. Why is it so? Have you seen a newborn baby so chubby, right? And as the child grows, that chubby fat goes and the muscle develops, right? Same thing happens in the arm. Initially, the baby is very chubby. It has fat, right? And as the child grows, this fat reduces and the muscle mass increases. So what happens? The overall thickness, the overall circumference of the arm, that remains constant, right? So if this is the arm of the child, initially it was fat. Now the fat is decreasing, but the muscle is increasing. So overall circumference, it remains the constant, right? Because of the replacement of the fat with the muscle, the circumference remains constant in the age group 6 months to 5 years of age. And because this is an age-independent parameter, it is used very importantly in screening of malnutrition, right? We have this beautiful, colorful tape over here. What is this tape called? Can anyone tell me what is this tape? A very important question for your exam. A colorful tape with three colors, red, yellow, green. What is this tape and where it is used? Yes, this is nothing but Shakir's tape. Shakir's tape. Where do we use this Shakir's tape? We use this Shakir's tape for the community screening purposes. Right? In a community, if the screening person, the Anganwadi worker or ANM, does not know how to read the values, definitely by seeing the colors, she can identify if the child is malnourished or what. Right? Now, what are these colors that are mentioned over here? I can see there is red, there is yellow, there is green. What is red? Can you closely see? Red. Yes, this red is less than 11.5, less than 11.5. Right? So red is mid-upper arm circumference less than 11.5. What is yellow? Yellow is 11.5 to 12.5. And what is green? Green is more than 12.5 centimeter. right? So if my child is lying within the green zone, that is the mid-upper arm circumference is more than 12.5, then the nourishment of the child is considered to be normal. But if the child's mid-upper arm circumference is less than 11.5 centimeter, the child is severely malnourished, right? And in between the yellow zone, the child is malnourished, right? So these are the important age-dependent parameters and age-independent parameters, right? Now coming to again a very important question for your exam, the growth curves, the Scammon curves, right? Here and there in each of your exam, alternative exam, either there is going to be a statement-based question or an image-based question, and they ask you about these curves. What are these curves? If you read closely, then the laws of growth say that each tissue grow at a different rate. Each tissue grow at a different rate, right? And to depict that, we have these growth curves that are also known as Scammon curves. Look at the first curve, curve A. What is happening over here? Initially, there is rapid growth. Initially, there is rapid growth in the initial 2 years of life, and thereafter, there is little to no growth. Uh, Overall, a plateau is achieved thereafter, right? And we have just read about head circumference. I told you that the head size maximally grows. It grows up to 90% of the adult size by the end of 2 years, right? So this is nothing but the curve for neural growth. Neural growth, right? In the initial 2 years of life, there is going to be maximal growth and thereafter little to no growth. This is the growth curve depicting neural growth. Moving on to curve B. What can you see in curve B? Initially, there is little to no growth, flat line, initial little to no growth, and thereafter there is sudden spurt. Thereafter there is sudden spurt. This is seen in sexual growth or gonadal growth. Sexual growth or gonadal growth. आदित्य के पास है मम्मी sexual growth or gonadal growth. This is achieved by puberty, right? So initially no growth, thereafter sudden spurt. Now comes curve C. Curve C. That is S-shaped curve. Initially rapid growth, little to no growth, then again rapid growth. This is seen with respect to somatic growth. Somatic growth, right? This is sigmoid shaped curve. S for sigmoid, S for somatic, right? We have seen that in the initial year, the weight doubles, triples, right? Within the 5 months, it doubles, then triples, then become 4 times. And thereafter, there is plateau. And again, as soon as the child hits puberty, again, there is going to be increase in the number and size of cells, right? And somatic growth will be higher side. So S-shaped curve is for somatic growth. And lastly, we have this curve where you can see there is a single peak in between 4 to 8 years of age. What is this? This is the curve for lymphoid growth. Lymphoid growth. Lymphoid growth. Is the voice echoing? Is it better now? Okay, so we have discussed four curves. Okay, so we have discussed four curves. There is neural growth curve, sexual growth curve, sigmoid shape, somatic growth curve, and lymphoid growth curve. Right? Important curve for your exam. You can't afford to mark these simple questions wrong. Right? In each of the exam, either there is a statement-based question or a diagrammatic question where they show these graphs and ask you about it. Right? So very simple. You can understand very nicely. Now, after growth, let's talk about a very dreaded topic, that is development, right? Before each and every class, I get a lot of messages that, ma'am, please cover development in thorough detail, right? So before moving into development, let's look at some images out there, right? Let's look at into some images down there. Okay. So what is this first image? Can anyone tell me what is this first image? This pink curve. What is this? What is this pink curve? What type of growth chart is it? Yes, it's WHO growth chart. WHO growth chart, right? If a child comes to me, there's age over the x-axis and weight over the y-axis. This is a weight for age chart. It is pink hair, so it is for girls. For boys, the chart is of blue color, right? For boys, it is of blue color. Some questions that are asked pertaining to this graph now, right? What type of growth charts are this? Are these standard growth charts or reference growth charts? These are standard growth charts, standard growth chart. What do I mean by standard growth charts? Standard growth charts are those growth charts in which I develop a standard, right? For example, if I say that I will only collect data of exclusively breastfed children, right? That means I have set a standard for my charts, right? That only exclusively breastfed children are going to be enrolled. Those who are formula fed or mixed fed won't be enrolled. So I set a standard for my charts, right? So this is standardized growth chart. On the other hand, if I just sit in my office and record the data of each and every child that is coming down without looking whether this child is breastfed, formula fed, animal milk fed, that is reference growth chart. Standard growth charts are used, they are better. Reference growth chart give a picture of that particular population, but they're not used that frequently, right? So standard growth charts, these are the standard growth charts. In here, the standard was exclusively breastfed babies. It is also referred to as MGRS, that is multi-centric growth reference study, gave this chart. Here we collected data from 6 countries. They asked these 6 countries. What are these 6 countries? You remember by the mnemonic, you are a big no. You are a big no, right? That's how I reject boys. You are a big no, right? How do you remember the countries? U is for USA, that is United States. B is Brazil. I is India. G is Ghana. N is Norway. O is Oman, right? The voice is still echoing. Is the voice still echoing? Or should I continue? Okay, so moving further after this growth chart, we have seen some devices earlier where where we were measuring the length or the height. First device, can you name it? We all know what is this device. Do we measure length or height from with it? We measure the length from it, used in less than 2 years of child. What is this device? What is this device? This device is, yes, infantometer. Infantometer. Voice is echoing. Let me ask the support to make changes. Okay, let's continue. I think it will get resolved. Okay, so coming to the next device, the second device, device B, right? Okay, so let's start again. We have the second device that is used to measure the height. That is for above 2 years of age. What is this device called? This device is nothing but stadiometer. 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 Right? Now moving to this device, this colorful tape we just discussed. What is this tape? The name of this tape is Sharker's tape. And we use this for community screening of malnutrition. Right? It has 3 zones, red, yellow, green. Red is less than 11.5. Yellow is 11.5 to 12.5 centimeter. And green is more than 12.5 centimeter. Green means well nourished. Less than 11.5 means severely malnourished. And yellow zone is malnourished. Right? Another age independent parameter is this. What is this? What is this device? This device is called as Harpendon's caliper. This is Harpendon's caliper, and by this we measure the skin fold thickness. Skin fold thickness. Yet another age independent parameter, and the most common site that we use is this site only, that is your scapula. Right? Apart from that, triceps could also be used. Okay. So now moving down to development aspect. Development aspect. Right? Before we will begin with the developmental milestones, I want to tell you a very brief concept of how to remember these milestones. Right? Whenever I'm assessing the development of the child, I'm going to check the development in 4 domains: gross motor, fine motor, your language, that is verbal milestones, and then social milestones, how we are interacting with each other, that's social milestone. Right? Gross motor means my gross bodily movements: sitting, walking, running, standing, right? And fine motor is the fine activity of the fingers. How the child is holding the objects, how the child is going to use it for writing or having food, right? That's fine motor skills. Then comes the language, how the child is going to form words and then sentences and then tell stories, right? And lastly, we have social, how the child is going to interact with people around. That's the social milestones. So whenever we are discussing the gross motor milestones, I do 3 maneuvers. I'm going to do 3 maneuvers. Look at this first maneuver. This maneuver is known as pull to sit maneuver. Pull to sit maneuver. What I'm doing, the child is lying down on the back. I'm holding the hands and pulling the child to make him sit down. Pulling the child to make him sit down. We all know that development happens in which direction? The development happens in which direction? If this is my child, the direction of development is cephalocaudal, cephalocaudal and proximal to distal. Proximal to distal. That means my trunk is going to develop first and thereafter my fine motor movements. Right? So if I do this pull to sit maneuver, I'll get to know about the neck holding. I will also get to know about the truncal control, right? We all know that neck holding comes at 3 months of the age. So if I do this pull to sit maneuver before 3 months of the age, what is going to happen? There's going to be head lag. At 3 months of the age, the child will hold the neck in the line. And after that, the child will try to sit, right? So look at these 3 images now. In this pull to sit maneuver, what is happening? I'm pulling the child, pull to sit maneuver, and I can see the head is lagging. Head is lagging, right? Head is lagging. So this is before 3 months or after 3 months or at 3 months. At 3 months, I know head control should be there, neck control should be there. Here, the head is lagging behind. So this is nothing but before 3 months, this happens at 4 weeks of age. 4 weeks of age, right? Moving down to this image, can you see here? When I'm doing this pull to sit maneuver, the head lies within the line of the back, right? The child is able to control the head, able to control the neck. This happens at 3 months of age. This happens at 3 months of age. After that, now when I'm pulling the child to sit, can you see in this image? When I'm pulling the child to sit, what is happening here? Now the child is trying to sit. He's able to help me a little to make him sit. Here, not just the head control, but a little trunk control is also coming. This is after 3 months of age. This is at 4 months. At 4 months. Right? So remember these three images. First image, if the head is completely lagging, 4 weeks, head in line with the back, that is 3 months. If the head is above, the child is trying to sit, he's able to help you a little to make him sit. That means a little truncal control is also coming. This is above 3 months of age, that is at 4 months of age. Right? After achieving the truncal control, now the child will try to sit. Initially, the child will sit like this. The child is taking support in the hands and sitting. What is this known as? Sitting with support, right? Sitting with support. This is sitting with support, right? And what is this position known as? This position is known as tripod position. Tripod position. When is this achieved? This is achieved at 6 months of age. 6 months of age, right? Thereafter comes this. This is sitting without support. Now the child is not taking the support of the two arms, right? This is sitting without support. This is at 8 months of age. 8 months of age, right? Initially, the child is going to sit with support, tripod position 6 months, thereafter 8 months. Now, we discussed this maneuver, that was pull to sit maneuver. Now, moving to the second way in which we are going to assess the child. That is this position. What is this position known as? I'm doing ventral suspension. I'm doing ventral suspension. Ventral suspension. What is ventral suspension? Have you seen Bahubali? How the Bahubali is lifted up? The back is lying on the palm and the baby is lifted like this. That is dorsal suspension. Here, this is Ulta Bahubali, right? Ventrally, I'm holding the child. This is ventral suspension. Here also, I'm checking the head control, the trunk control, right? If the child is below 3 months of age, where no head control is there, the back would be curved, head would be hanging. After that, once the child has achieved the head control, the head would be lifted up. Full control, the head would be lifted above the back, right? So look at these three images. Look at these three images, right? We have the first image where I'm doing the ventral suspension, and what can I see? I can see the back is curved, the head is hanging down, right? This is before 3 months, at 3 months, or after 3 months. This is at 4 weeks, before 3 months of age, right? Now look at this baby. Here the head is in line with the back. And look at this image. Here the head is above the back, right? So here in this image, see, now the complete head control has happened. Now the child can lift the head above the back, plane of the back, right? So this is at 3 months, and this one is in between that is at 2 months of age, right? So 4 weeks, 2 months, 3 months. So we have discussed two maneuvers. First is pull to sit and the second is ventral suspension. Now coming to the third way in which we are going to assess the development, that is the prone position. Prone position. We make the child lie in prone position, and depending upon the tone of the child and the ability of the child to lift the head off the ground, we are going to assess the development. Look at this child. The legs are tucked in, right? Flexed lower limbs, flexed hips, flexed thighs, right? And the hip level is slightly elevated because of this flexion. This is at 2 weeks of age. Now, as the child grows, this flexion goes, and now the lower limb is extended, the pelvis lies flat now. This is at 6 weeks of age. And after that, once the head is lifted off the ground, this is at 8 weeks of age. Right? So 2 weeks, 6 weeks, 8 weeks. And thereafter, can you see in this image what is happening? Now, some chest is also lifted off the ground. This is a complete head control, complete neck control that happens at 3 months of age. 3 months of age. Right? 3 months of age. Now coming to some other development gross motor milestones, can you see what the child is doing here? The child is standing. Is the child standing with support or without support? The child is standing with support. When does this come? This comes at 9 months of age. Then we have this child. This child is standing without support. Right? This happens at 12 months of age. Right? So at the first birthday of the child is going to stand without support. The child can stand independently and cut the cake. Right? So 12 months, very important milestone. Now the child can stand without the support. In between, the child tries to move. The child will move on the four limbs. I have two images over here. What is crawling? What is creeping? Can you see this image A? Here the abdomen is touching the ground. And here the abdomen is lifted off the ground, right? So firstly, when the child is moving on all the four limbs, the abdomen would be touching. As the child grows, now the abdomen would be lifted off the ground, right? So what is crawling, what is creeping over here? A is crawling or B is crawling? When the abdomen is touching the ground, it is crawling. It is crawling. And when the abdomen is lifted off the ground, it's creeping. It's creeping, right? When the abdomen is touching the ground, it's crawling. And when it is lifted off the ground, it's creeping. Crawling comes at 8 months of age, whereas creeping comes at 10 months of age. It comes at 10 months of age, right? Now moving down, can you see here the child is trying to walk? Initially, the child is holding the hand of the father and trying to walk. So this is walking with support, right? So this is walking with support. This walking with support comes at 12 months of age. So on the first birthday, the child is standing independently. The child does not need any support to stand and will cut the cake independently. But to walk, to take gifts or give return gifts, the child would need support, right? To walk down, the child is going to need a support in the first birthday. First birthday, the child will cut independently, stand independently, but has to walk with support. Now look at this child. This child is walking without any support. This would happen obviously after 1 year of age. This happens at 15 months. 15 months. Walking without support. Right? Now yet another important milestone. What is this milestone? The baby is looking at the mirror and enjoying playing with the mirror. What is this known as? This is known as mirror play. This is known as mirror play. And it comes by 6 months of age. 6 months of age. Right? Now coming to this fine motor milestone, what is happening here? The child is holding a ball within the two fingers, right? Using the index finger, thumb, and also middle finger. What is this? This is pincer grasp. Is it mature or immature? It is immature pincer grasp. When the child holds the object in between just the thumb and the index finger and makes like okay like sign, this is mature pincer grasp. But when the child is not making okay and using the accessory fingers to hold the object, that is immature pincer grasp. So immature pincer grasp, it comes at 9 months of age, and mature grasp, it comes at 12 months of age. 12 months of age, right? So let's discuss the developmental milestones one by one now. As I told you that whenever we are going to assess the development, we are going to look at the four domains. What are those four domains? These are gross motor, fine motor, social milestones, and language milestones. Language milestones, right? Language milestones. So let's discuss one by one each of them. What's important in the gross motor milestone is the direction of development. The direction of development is cephalocaudal and proximal to distal. Proximal to distal, right? That means firstly the head will develop, then the trunk. So the child will first hold the head, then the trunk and sit, and then stand, right? And within the limb, firstly the child proximal muscles are going to develop, and thereafter distal muscles are going to develop. Okay, so at 3 months of the age, we all know an important gross motor milestone, that is the neck holding comes. Neck holding comes. At 6 months of the age, the child learns to sit with support. That is the tripod position, right? At 8 months of age, the child will now sit without support. Between sitting and neck holding, now the child will try to roll over, right? When the child is trying to sit, the child will try to roll over. So in between 4 to 6 months, the child will roll over. At 9 months of the age, what happens? The child stands with support. After sitting, the child will stand. Initially, the child will stand with support. And finally, at 12 months of the age, the child will stand without support. At 15 months of the age, what happens now? The child can now walk without support. Walk without support. At 12 months, on the first birthday, what was the child doing? Standing without any support and cutting the cake. And for walking, the child was needing support. At 15 months, now the child will walk without support. As soon as we turn 18, we all run away, right? We all want to explore the world. We all want to do ye jawani hai diwani, right? So at 18 months also, the child learns how to run. Right? So at 18 months, the child will now run. At 2 years of age, the child will now jump and walk backwards. At 3 years of the age, the child is going to use a three-wheel tricycle. The child can now ride a tricycle. At 4 years of age, the child will hop or skip on 2 feet. Crawling and creeping. What is happening in crawling? In crawling, what was happening? The abdomen was touching the ground. Whereas in creeping, it was off the ground. What comes first, crawling or creeping? It's the crawling that comes first. Crawling comes at 8 months of age and creeping comes at 10 months of age. In gross motor milestone only, very important milestones is the stair milestones. When the child moves up the stairs, down the stair, is the child using 1 foot on one step or 2 feet on one step, right? Initially, what the child does, the child will put both the feet on one step. That is 2 feet on one step and will go upstairs and downstairs, right? What is easier, going upstairs or downstairs? Upstairs is going easier. So firstly, the child will learn how to go upstairs using 1 foot on each step, right? And thereafter, the child will learn how to come downstairs on 1 foot on each step, right? So this is known as the stairs milestone. These are the stairs milestone. 2 feet on each step. Upstairs and downstairs comes at 2 years of age. 1 feet per step. Upstairs, that means using the alternate step, it comes at 3 years of age. And finally downstairs at 4 years of age. 4 years of age. So this completes the gross motor milestones. Our gross motor milestones are completed. Now moving down to fine motor milestones. Fine motor milestones. Initially, these are fine motor are the fine movements of the hand muscles, right? The still muscles here. So at 4 months of the age, what milestone do we appreciate? At 4 months of the age, finally the child loses the palmar grasp. So what is the palmar grasp? Palmar grasp is a primitive milestone. If you look at a newborn baby and stroke the side of the palm of the baby, the child will hold it. This is palmar reflex. Palmar reflex, right? So this is reflex that is happening with the baby. The baby is not trying to grasp your finger like you. It's just the reflex, right? There is a reflex. Because of that, the child is holding that finger or the object, right? And to attain new milestones, primitive milestones must be lost. Similarly, when you're getting into a new relationship, you have to forget your ex, right? So all the primitive reflexes must be lost to attain new milestones. So this palmar reflex is lost so that the baby can voluntarily grasp things. Before that, it is a reflex that is not in control of the baby. This has to go so that the baby can voluntarily grasp the toy or rattle, whatever the baby wants to hold. So this palmar grasp reflex goes before 4 months of the age so that the baby can finally grasp a rattle or a toy at 4 months of age. Right? And now something interesting is in the hands of the baby, the toy and rattle, the baby will try to eat it. This is known as mouthing. Whatever the child is having, the child try to sense it through the mouth. This is known as mouthing, right? After that, now the child will try to hold variety of objects. Initially, the child will use both the hands. This is known as the bidextrous approach, where the child uses both the hands to hold the object. Thereafter, the child will realize I can hold the object in one single hand also. This using both the hands is bidextrous grasp. That comes at 5 months of age. Thereafter, it is unidextrous grasp, that is holding with one hand, right? And thereafter, the child will realize why I'm holding things like that with my whole hand. I'm human. God has given me an opposable thumb. I can hold things like that also, right? The child will try to hold the things in a pincer grasp-like position. So before that, there will be a radial grasp where the child will try to hold the things from the radial side. And then comes pincer grasp. Initially, it will be immature, where along with the index finger and thumb finger, accessory fingers would also be used. This is the immature grasp at 9 months of age, and then the mature grasp at 12 months of age. And once mature grasp is there, the child can hold a pencil, right? The child can hold a pencil and the child will make various diagrams, drawings, sketches, right? So depending upon these sketches, we can estimate the developmental age of the child. The child can draw a line at 2 years of age. You can see a line has two ends. So a line is drawn at 2 years of age. A circle at 3 years of age. A cross at 4 years of age. This rectangle at 4.5 years of age. Triangle at 5 years of age. Triangle is at 5 years of age. This rhomboid kite-like shape at 6 to 7 years of age, cylinder at 9 years, and this beautiful cube at 11 years of age. 11 years of age, right? So a very famous question that they ask in an exam because they know you can get confused. So we discussed tricycle, right? Tricycle. Tricycle was at 3 years of age. But triangle is at 5 years of age. So don't confuse the two, right? Tricycle, three-tire cycle that the child learns by 3 years. Triangle, though it is a three-sided figure, but it is drawn at, the child can draw it at 5 years of age, right? So tricycle 3 year, triangle 5 years, right? Now, using our distal muscles, using our fingers, we do a very important thing that is very important for our day-to-day life also. That is the dressing skills, right? Daily we dress and undress ourselves. What is easier, dressing up or undressing? It is the undressing that is easier and more pleasurable also, right? So firstly, the child will learn to undress himself or herself. Firstly, the child will need help, and thereafter the child will do without help. So firstly, the child learns how to undress with help and then dress with help. So undressing with help comes at 2 years of age, and dressing with help comes at 3 years of age. And thereafter, the child can undress and dress without help. This comes at 5 years of age. 5 years of age. And in dressing also a very skillful task is buttoning and unbuttoning. Buttoning and unbuttoning. Again, unbuttoning is easier. So it comes at 3 years of age and buttoning at 4 years of age. Buttoning at 4 years of age. Right? So I have separated these dressing milestones. Similarly, in gross motor milestone, stair milestone, I have made a separate table. So that is easier for you to remember. 2, 3, 4, 2, 3, 5, 3, 4. Right? So this completes fine motor milestone. Yet another important image-based question that is asked is this cubes. Mostly in your final year Viva exams also they ask you to bring this fancy developmental kit that has these cubes in it. What we do with these cubes, we give these cubes to the child and ask the child to make various figures. And depending upon what all structures the child can make, we can assess the development age, we can guess the developmental age, right? So what I do, how I learn this is, I ask the child firstly to make a tower of these cubes. What do I mean by that tower? That means I will stack the cube one over the other and make a building, make a tower, right? So initially I'll tell the child make a tower of 2 cubes, then make a tower of 6 cubes, then make a tower of 9 cubes. That means a 9-story tower is made now, right? Now to go to this tower, the child will need a train. So I will ask the child to make a train. How the child makes the train? By arranging these blocks horizontally now. Firstly, the child will make this train by placing horizontally cubes. And to move this train definitely needs an engine, a chimney. So the child will now add a chimney over it. That is 1 cube vertically over the first cube. This is train without chimney. This is train with chimney, right? Now this train has to reach this 9-tube tower. To do so, the child has to cross a bridge. Firstly, the child will cross this 3-gated bridge that is made out of 3 cubes. And after that, this 5-gated bridge that is made out of 5 cubes. Right now, the train has reached the tower through the bridge. Now, to reach to the top of the tower, this is a 9-story building. I will need a staircase. Then the child will make a staircase like this out of the cubes. Right? Why I told you this stupid story? Because the sequence that is going to help us in the exam. Firstly, tower, 2 cubes, 6 cubes, 9 cubes. Then train without chimney, with chimney. Then bridge, 3-gated, 5-gated, and lastly staircase. Right now, let us remember. Let us learn and revise together what ages the child can make what structure. So 2 cubes tower, the child can make in 15 months of age. 6 cubes at 2 years of age, 9 cubes at 3 years of age. Train without chimney, 2 years. With chimney, 2.5 years. Bridge, 3-gated, 3 cubes, 4 years. And 5-gated, 5 years. And finally, S for staircase, S for 6. The staircase the child can make at 6 years of age. 6 years of age. Right? So this totally completes your fine motor milestones in which we discussed various scribbling patterns, grasp, dressing skills, undressing skills, and cubes. Right? I hope you will remember the story, and on the basis of the story, you can easily rule out options, mark the options, right? And the sequence is really important, right? And development sequence is really important. Sequence will always remains the same. The child will always first learn how to hold the neck, then the trunk, then stand, right? And nowhere in the world the child first learns how to stand and then walk. right? This is the normal sequence. This normal sequence is really important for you. Moving down to the next domain, that is the social milestones. Social milestones. What do I mean by social milestones? It is how the baby interacts with the surroundings, right? Surrounding people. How the baby interacts with the mother, father, stranger, friends, right? So initially, what happens? The child has spontaneous smile, right? Have you ever seen a newborn smiling, right? Without any reason, the newborn smiles, that's spontaneous smile. My grandmother used to say the child is remembering the past birth and that's why smiling, but it is definitely not such. That's a milestone. At 2 months of age, the child will now have a social smile. That means the child will now smile with respect to the cues. The child will socially smile, right? After that, the child will realize that out of all the people around, I'm passing smile, though I'm passing a social smile to each and every one. My mother is really special. She's giving me feeds, right? She's caring for me. So child will at 3 months of age recognize the mother and give special regard to the mother. This is mother regard that comes at 3 months of age, right? After that, what happens? Child will lie down and look at the hands like this, right? Look at the own hands like this. What the child is doing, the child is appreciating his own hands. This is hand regard, right? Child initially gives regard to the mother, and now the child is recognizing self, giving regard to himself, giving this hand regard, right? And this is a developmental milestone. It is seen that even blind babies do that, right? This hand regard, it begins at 12 weeks, begins at 12 weeks, that is 3 months only, and it ends also at 20 weeks. Right? This cannot go on, so it ends also. It comes at 12 weeks and ends by 20 weeks. So by now the child has recognized the mother and himself. Right? Now comes the 6 months where the child will do mirror play. Right? 6 months the child will do mirror play. In the mirror, the child will look at himself and find himself really, really sexy. Right? So S for 6 months, X for sexy. Right? I remember it that way. You can also remember it that way. We can make studying fun also. Right? So now the child recognizes self and the mother. Now, whatever stranger comes in, the child will have anxiety. This is known as stranger anxiety. It comes after 6 months, 6 to 7 months, the child is going to have stranger anxiety. Right? Then comes a really important milestone, that is object permanence. Object permanence. What happens before 9 months of the age? If you show an object to a child and then hide it away, the child won't look for it, right? For the child, whatever is in the vision of the child is in the universe. Whatever goes out of the vision is out of the universe. What a beautiful place to live in, right? So, uh, before 9 months, there is no object permanence. If you remove the object, the child won't look for it. That is out of his universe. But after 9 months, object permanence set in. If you show an object and then hide it, the child will try to look for it. He understands that objects are permanent. And if you hide for it, that doesn't mean that the object has disappeared from the universe. So this is the object permanence that comes at 9 months of the age. And once this object permanence sets in, the child needs to learn to say bye to things. The child will also learn to wave bye-bye at 9 months of age. Right? So at 9 months, two important milestones, that is object permanence and waving bye-bye counts. Right? Now, after that, all the drama will begin, right? Now the object permanence has set in, all the drama in life would come. The child will do imitation, mimicry. We all understand what is this imitation, mimicry, right? Firstly, the child will imitate and mimic sounds. This comes at 7 to 9 months of age. Then act, that comes at 9 to 12 months of age. Then domestic mimicry, that comes at 18 months of age. Domestic mimicry means the child will try to copy the things that day to day we do in our domestic life, right? Cleaning, maybe cooking, right? All of this, the child will try to copy. After that, the child will be able to tell three things, introduce himself, name, age, gender. These three things the child can tell at 3 years of age. Handedness, that is preference of one hand over the other, also comes at this age, right? At 3 years only. These three things the child can say, name, age, gender, and handedness also comes. Then comes right and left discrimination. It comes at 4 years of age. Right? Handedness and left and right discrimination are two different things. What do handedness means? Handedness means preferential usage of one hand over the other. But left to right discrimination means knowing that I am using right side more than the left side. That is right to left discrimination. That comes later on at 4 years of age. Within the social milestones, important milestone is interaction and play. Firstly, the child is at home in a very safe environment. The child is very comfortable with the parents. And by 18 months, the child is now growing and loving the parents more and more with each day. Right? So by 18 months of age, the child hugs the parents. By 15 months of the age, by 15 months of the age, the child hugs the parents. And by 18 months, the child kisses the parents. But sooner or later, parents have to leave the child away to go out and work, right? And after this intense love that has developed between the parents and the child, now finally the child has to face separation anxiety or approachment. This is approached at 24 to 30 months of age, right? By 2 years of age, the child will feel the separation anxiety, right? Now the child will realize that enough with my parents, I actually need to go out and make friends of my own. Remember your first year of MBBS? Maybe a group of strangers were sitting together, and by the end of the final year, they become best of friends. So what happened on the first day? You must be really hesitant to talk. So you must be busy on your phone, and your friend that was sitting beside you must be busy on your phone. So this is nothing but parallel play. What happens initially? The child will go out, meet new friends, but won't interact with each other. They will just sit together and do their own thing, right? This is parallel play, comes at 2 years of age. Then they will exchange toys and play together. This is known as cooperative play, comes at 3 years of age. And finally, they'll make a whole group and do group play or role play. This comes at 4 years of age. Right? So this is all about interaction and playing, developmental milestones. We are done with the social milestones. Now moving to the last domain, that is the language milestone. That is using the verbal mechanism to interact. Right? The child is going to produce sounds to interact. Initially, the child coos. This comes at 2 months of age. Then the child will laugh out loud. This is at 4 months of age. कर दिया मैंने ना अभी हाँ मैं देखती हूँ Is the voice better now? Voice any better now?
जी मैम आवाज बेटर है.
Sitting beside you must be better है अभी?
यस मैम.
Okay. Let's begin. We're talking about language milestone, that is using the voice to express yourself, to interact with our surroundings. So firstly, the child will learn how to coo. This comes at 2 months of age. Then the child will laugh out loud. This comes at 4 months of age. Then the child will say monosyllables. What are monosyllables? Like ma, pa, da, right? These are monosyllables. These comes at 6 months of age. And what are bisyllables? Bisyllables are made by joining these monosyllables like mama, papa, dada, right? This comes after monosyllables, that is 9 months of age. And finally, on the first birthday, that is 12 months of age, the child is going to speak his first real word, right? So 12 months on the first birthday, we have discussed the child will stand without support, walk with support, and also the child is going to speak the first real word. And in fine motor milestone, we discuss the child will have a mature pincer grasp. right? Now, after the first real word means when the child actually knows the meaning of that real word. Before that, if you ask your parents, they usually say that your first word was either mama, papa, dada, right? But these words are not real words. The child is just joining monosyllables to make bisyllables, right? This is not the real word. The real word which the child knows the meaning of, that comes at 12 months of age, right? After that, the vocabulary of the child will increase, and by 15 months, the child is going to have vocabulary of 4 to 6 words. Child will be able to name common object and will have a jargon speech. This jargon speech is asked in an exam when this jargon speech comes. It's around 15 months of age. Then comes picture naming. If you show a picture to the child and ask the child to name it, the child would be able to name it by 18 months of age. By 2 years, 2 word sentences would be formed. Pani do, khana do, give food, give water, right? Go away. These are all 2 word sentences. The child can make this at 2 years of age. And finally, the child can use pronouns like I, me, you at 3 years of age. After that, the child will be able to recite a poem, tell a story. And how does the story start? Once upon a time. That means referring to the past tense. All this comes at 4 years of age. And referring to the future tense and asking the meaning of words, this comes at 5 years of age. This comes at 5 years of age. 5 years of age, right? So we have completed the general pediatric section of growth and development. Now moving to nutrition segment, right? If I talk about nutrition, for your FMG exam, what is important is knowing breast milk. Important is knowing the breast milk, certain definitions associated with nutrition, like what is undernutrition, what is malnutrition, what is overnutrition, what is severe malnutrition, right? All of these definitions you need to know. And SAM, mostly the criteria for SAM is important. And apart from that, vitamin deficiencies. Vitamin deficiencies is important topic for your FMG exam. Almost in each and every exam, 2, 3, sometimes 4 questions out of these vitamin deficiency are asked. It is an overlapping topic between biochemistry and nutrition and pediatrics, right? So let's begin. Firstly, let's talk about human milk and cow milk. That is an important topic, right? We all know that human milk is a very important source of nutrition. Up to how many months of age exclusive breastfeeding is to be done? Exclusive breastfeeding. Exclusive breastfeeding. For how many months exclusive breastfeeding is to be done? This exclusive breastfeeding is to be done till 6 months of age. And what do I mean by this exclusive breastfeeding? Can I give water? No. Can I give honey? No. Exclusive breastfeeding means only and only breast milk is to be given. Apart from that, the vitamin drops or some medication that is prescribed by a doctor can be given. Vitamin or medication that the pediatrician has prescribed can be given. But apart from that, nothing else. No water, no honey, nothing. Right? So this was exclusive breastfeeding. What is important for your exam is the human breast milk and cow milk composition and what are the differences that are out there, right? Firstly, let's talk about the composition of this human breast milk and cow milk. Okay, firstly, let's talk about the macronutrients, that is the proteins, carbs, fat. If we talk about the human milk, the protein quantity wise, it's less, right? It's close to 1 gram per deciliter, 1 gram per deciliter. Whereas here it is 4 grams, 4 grams, right? 4 grams. 4 grams. 4 grams. Though the quantity is less, it's better absorbed. It is better absorbed, better utilized, because the quality of protein is better. Quality of the protein is better, right? And also the newborn's baby kidney cannot tolerate this much amount of high amount of protein load. So best is this human breast milk that has good proteins and enough proteins that can be easily processed by the newborn baby, right? And if you look at the quality of protein, the quality of protein in human breast milk is better. If any of you is going out there in gym and working on their body, you must be taking protein, this whey protein. Is that a good quality protein? Yes, that's a good quality protein, better absorbed, better utilized. So if you look at the whey to casein ratio in the human breast milk, it is 60:40. That means human breast milk is whey predominant protein. Whey predominant protein. That means a better protein source. Whereas in cow milk, this whey to casein ratio is actually 20:80. That means casein is 80%. This is a casein predominant milk. Casein predominant milk. Right? Casein predominant milk. What is the disadvantage of this casein predominant milk? The disadvantage is that this casein will form coagulum in the gut. This casein will form coagulum in the gut, won't get absorbed, and the child will get constipated. Right? So better protein is human breast milk protein. If you look at the calcium to phosphate ratio, then the calcium to phosphate ratio in human milk is in the ideal proportion of 2:1. The calcium to phosphate ratio is in the ideal proportion of 2:1. This ideal proportion promotes the better absorption and utilization of calcium, right? Promotes better absorption of the calcium. Whereas cow's milk it is phosphate high. So because of that, the calcium absorption is not that efficient. Right? Now coming down to fats. If you look at the fats in human milk again are better quality. It is rich in PUFAs, rich in DHAs, which is very important for the brain and retina development. Right? That's why it is seen that the babies who are fed with human milk, human breast milk, mother's milk, they have more IQ as compared to those who are fed with animal milk or formula milk. Right? That's because the human milk has DHA that helps in the brain development, the retinal development. Right? Moving down to carbs. The major carbohydrate that is there in the human milk is lactose. It is 7 grams, that it is 7 grams, very high amount of lactose, right? What is the advantage of this high sugar concentration? It decreases the risk of hypoglycemia. And also this lactose sugar would promote the growth of lactobacilli, that is the good bacteria, right? Growth of lactobacilli, which in turn will help in better absorption of calcium and other nutrients, right? Here it is 4 grams, lesser, right? Moving down to vitamins, if you look at the human breast milk, it is sufficient in most of the vitamins, except it is deficient in vitamin D and K. That's why at birth only we supplement with vitamin K, right? We give injection vitamin K 1 mg intramuscularly, right? This given at the birth only. If the weight of the child is less than 1 kg, then we give half of that dose, that is 0.5 mg, right? And when we talk about vitamin D, till the child is breastfed, we continue vitamin D drops, supplements. We give 400 international units orally to all the babies who are receiving this breast milk, right? Supplementation is universal. Vitamin K to hum birth pe laga dete hain. Vitamin K injection we give at birth only, and we give this vitamin drops till 6 months of age when the child is exclusively fed. In some cases, we continue that till 1 year of age, right? And what about cow milk? Cow milk is specifically deficient in vitamin C. In fact, almost all the animal milks, they are deficient in vitamin C. So what kind of questions can be formed out of this? If they give you that a child presents to you with bleeding, a child presents to you with bleeding, and the child has history of home delivery. This child was home delivered. That means this child did not receive the vitamin K injection at birth, right? Bleeding in a child who was home delivered. So, which vitamin is responsible for this bleeding? It is the vitamin K that is responsible for the bleeding. And this is nothing but hemorrhagic disease of newborn. Hemorrhagic disease of newborn, right? We give vitamin K for the prevention of hemorrhagic disease of newborn. If the similar question is out there and they say the child is there with bleeding and the child is on exclusive animal milk diet. So this is nothing but vitamin C deficiency associated bleeding, that is scurvy, right? If the question is like, hello, अब आ रहा है? स्टार्ट करूँ ना फिर रिजन को? So there was some technical glitch as the voice were ignoring. We are not able to solve the issue per se, but I think it's getting better in between and then getting. Okay, so let's continue. Okay, so I just told you the possible questions that could be have been asked about this table. That a child with bleeding, home delivered, vitamin K deficiency, a child with bleeding on animal milk, vitamin C deficiency. Apart from that, a very important question, that is, they give you a baby with anemia, and this child is exclusively fed with goat milk. Goat milk. No, goat milk. Right? And they give you a picture where you see megaloblastic anemia. That means big size RBCs with hypersegmented neutrophils. Right? With hypersegmented neutrophils. So what is this? This is megaloblastic anemia, goat milk. So they ask you which vitamin is deficient in goat's milk. So I told you that in animal milk, vitamin C is deficient. But specifically, if they're asking about goat milk, then remember that specifically goat milk is deficient in folate. And because of this folate deficiency, the child can develop megaloblastic anemia. Apart from that, if the mother is vegan, then definitely the mother would be deficient in B12. And again, because of that, the child can develop B12 deficiency anemias. B12 deficiency anemias, right? B12 deficiency anemias. So it covers a very important topic, differentiating human breast milk from cow milk, right? So now let's move to an important topic of vitamin deficiencies. Vitamin deficiencies. So if we talk about vitamins, there are two types of vitamins. We have fat-soluble vitamins and water-soluble vitamins. We all know what are the four fat-soluble vitamins. We have vitamin A, D, E, and K. And in water-soluble vitamins, we have B complex vitamin and vitamin C. Right? Now, let's briefly discuss about these vitamins and what their deficiency causes and what is the exam points that you need to remember. Firstly, let's talk about B1, that is thiamine. B1, that is thiamine. We all know that deficiency of B1 thiamine causes beriberi, right? We have dry beriberi and wet beriberi. Dry beriberi affects the nerves, wet beriberi affects the cardiac tissue, right? In alcoholics specifically, we see this thiamine deficiency, and because of this thiamine deficiency, our typical constellation of symptoms is seen, that is Wernicke-Korsakoff syndrome. Here we see global confusion, ophthalmoplegia, and ataxia. This can be remembered by the mnemonic GOA, G-O-A, GOA, global confusion, ophthalmoplegia, and ataxia. Right? Coming to B2, that is riboflavin. That is the other name of B2, riboflavin. Right? Due to the deficiency of riboflavin, what is going to happen? There is going to be vascularization of cornea. Remember ribo as red, right? So there will be red vessels encroaching the cornea. So there will be vascularization of cornea, as you can see here. There will be redness over the mucosa, over the lips, over the tongue. That is glossitis, ciliitis, and there will be magenta colored tongue. And in skin, due to the deficiency of riboflavin, there could be seborrheic dermatitis. Right? Then we have B3, that is niacin. In niacin deficiency, what do you see? We see 3D disease, that is pellagra. We see diarrhea, dermatitis, dementia, and sometimes this fourth D is also considered, that is death, right? Then we have B5. B5, the other name is pantothenic acid. And how do we pull these pants over? We pull the pants over the feet. This is known as burning foot syndrome also referred to as nutritional melalgia. Nutritional melalgia. Then we have B6. that is pyridoxine. Due to this pyridoxine deficiency, a very important point for the exam, pyridoxine deficiency can cause neonatal seizures. Right? Pyridoxine deficiency can cause neonatal seizures. Apart from that, microcytic anemia, seizures, depression. Why this neonatal seizure is an important point is, in neonatal seizures, if you have given multiple anti-epileptics and still the child is not getting relieved of that seizure, then finally we give a trial of pyridoxine, because very rarely, because of the pyridoxine deficiency, there could be seizure, right? Then we have B7, that is biotin. A lot of girls take this biotin supplement for their skin and hair health. And this biotin deficiency is very poorly understood. But we know that this causes dermatitis, alopecia, muscular pain, hallucination. There's nothing like B8. We have B9, that is folic acid, right? This folic acid deficiency, we all know if a pregnant mother is deficient in folic acid, that can lead to neural tube defects. So deficiency leads to neural tube defects. Apart from that, megaloblastic anemia, neuropathy. We have then B12, that is cobalamin. Cobalamin deficiency can again lead to megaloblastic anemia, dementia, and SACD, that is subacute combined degeneration. And finally, coming to the last water-soluble vitamin, that is ascorbic acid, and we all know that the deficiency of this vitamin C leads to scurvy. Out of all of these water-soluble vitamins, the most important I feel for your exam, because a lot of questions have been asked repeatedly about this deficiency, is niacin deficiency. Remember niacin B3, the deficiency that causes pellagra, 3D disease, diarrhea, dementia, and the dermatitis, Casal necklace, right? This niacin deficiency can be caused due to a variety of reasons. If you look at this pathway, this is the biochemistry stem, right? Niacin is formed in our body from tryptophan, right? From tryptophan, this niacin is formed by kynurenine pathway, right? Apart from that, this tryptophan is also used for the production of serotonin by serotonin pathway. The serotonin further forms melatonin by HOMT enzyme and 5-HIAA, that is the metabolite by MAO-A and B enzyme, right? So whenever there is tryptophan deficiency, there's going to be niacin deficiency, right? Whenever there is tryptophan deficiency, there's going to be niacin deficiency. Also, in certain conditions where the production of serotonin is increased, all of the tryptophan would be used up in the production of serotonin, and then there will be niacin deficiency, right? Lastly, if there is some problem in the B6 in this kynurenine pathway, B6 is an important cofactor in this kynurenine pathway. So B6, that is pyridoxine deficiency, is there. I can also have this B3 niacin deficiency, right? So I made a table for that. First, where there is less tryptophan available to us. Hartneff's disease that hinders the absorption of tryptophan would lead to niacin deficiency. Next, we have carcinoid syndrome where there is overproduction of serotonin. So my whole tryptophan will go towards the serotonin production. This is carcinoid syndrome. Then we have B6 deficiency that will have kynurenine pathway defect and thus less production of niacin and niacin deficiency. And lastly, a very important question for exam, that they give a stem where the child is on maize or jowar based diet. The deficiency here is due to the increased leucine content in these maize and jowar that hinders the absorption of tryptophan and hence the production of niacin, right? Another question is about raw eggs. If the child is on raw egg diet, these raw eggs have avidin that binds B7 biotin and can cause biotin deficiency, right? And they ask then about the test with pertaining to each deficiency. For B1, we check for the RBC transketolase enzyme. For B2, we check for glutathione reductase. B6, RBC transaminases. For B9, that is folic acid, we do Figlu excretion or histidine load test. And finally, for B12, we check for serum methyl malonate levels. This is an overlapping topic between pediatrics and biochemistry and will be dealt in biochemistry in more detail. Right? Moving down to the fat soluble vitamins, we have A, D, E, and K. Vitamin A, we all know, has three active forms: retinol, retinal, and retinoic acid. It is the retinal that is important for the vision, and deficiency causes night blindness. We all know that the deficiency here causes night blindness. And what about the toxicity? These fat soluble vitamins, if ingested in higher amounts, will lead to toxicity also. So the toxicity of vitamin A leads affects the lysozymes, cause pseudotumor cerebri, exfoliative dermatitis, chronic fractures, right? Then comes vitamin D. The active form of vitamin D we all know is 125 DHCC. The deficiency causes rickets, osteomalacia, and excess would call calcinosis. We have vitamin E. The active form is alpha tocopherol. Alpha tocopherol, the deficiency causes hemolytic anemia, axonal degeneration, spinocerebellar ataxia, and the excess will cause thrombocytopenia. Lastly, we have vitamin K. In vitamin K, the active forms we have K1, K2, K3, phyloquinone, menadione, and menaquinone. And we all know the deficiency of vitamin K will lead to bleeding, hemorrhagic disease of newborn, and the excess leads to hemolysis. Hemolysis will lead to release of bilirubin, hyperbilirubinemia, and connectors, right? So this completes an important section of vitamin deficiency, a very important table, uh, an overlapping topic between biochemistry and pediatrics, a must know topic, you must revise this topic just one day before the exam, because a lot of questions are asked within the same exam, right? I have seen 6 questions coming in a single paper out of this vitamin deficiencies only. So a very favorite question of the examiner is a very important topic for your exam. Moving down just to the definitions of malnutrition. Remember the growth charts, right? Here, if something is in between two centiles, right? Within the two centiles, that is two standard deviation, that is normal. But anything beyond plus minus two standard deviation is considered to be abnormal. And anything beyond plus minus three standard deviation is considered to be severely abnormal. This malnutrition term actually refers to both undernutrition as well as overnutrition, right? But in India, overnutrition is not that a big problem. So we synonymously use malnutrition and undernutrition as to be the same, right? So I told you that anything beyond plus minus three standard deviation is going to be severely abnormal, and anything beyond plus minus two standard deviation is going to be abnormal. So if I say the weight for the height of the child is above third centile, to above three standard deviation, and the BMI for age is above 95th centile, this child would be labeled as obese or overweight. This is severely abnormal, right? This child will be obese. But if the weight for height is in between two standard deviation to three standard deviation, then this is abnormal, not severely abnormal. So this child will be overweight or obese. This child is overweight. Overweight. Right? Now the weight for the height, if I say, is below minus three standard deviation. So this child will be wasted or severely wasted. This child will be severely wasted. Severely wasted. Right? Severely wasted. What about this? Now here the weight for height is in between minus 2 standard deviation to minus 3 standard deviation. This child is wasted. Coming to the height, if the height is short, I say the child is stunted. If the height is severely short, I will label the child as severely stunted. So if the height for age is less than minus 3 standard deviation, this is severe stunting. This is severe stunting. And if the height for age is in between minus 2 to minus 3 standard deviation, this is stunting. This is stunting, right? So the crux here is anything beyond plus minus 2 standard deviation is abnormal. Anything beyond plus minus 3 standard deviation is going to be severely abnormal, right? Severely abnormal. Okay, now let's move down to yet another important table differentiating uh, acute versus chronic malnutrition. Okay, so what is acute malnutrition and what is chronic malnutrition? When we joined MBBS, most of us were coming out from our homes, from a very safe, secured environment into hostel place where we used to have mess food, right? Very less in nutritional value. So what used to happen initially, many of the MBBS students lose weight, right? Because they're eating way less and the food is also way less nutritious as compared to their homemade food. So what happens? They lose their weight, right? What about the height? Height is not that affected, right? Height is, in fact, we're adults, but still, height is not affected. So weight is severely affected, but once you start eating fine, you will gain weight again, right? So what happens in acute malnutrition? For a small period of time, because of the less intake of nutrients, the child is going to face malnutrition. Here, the child's weight will fall. This can happen in illness. This can happen when you are dieting, right? When you're restricted of these nutrients. So in acute malnutrition, for a small period of time, the intake of nutrients is less. So here the weight for age definitely will decrease. What about height? It will stay normal, right? Height will stay normal. The loss of intake or the less nutrition intake is just for a small period of time. It won't affect my height. What about weight for height? Height is normal. Weight is decreased. So my weight for height will also decrease. What about BMI? What is BMI? Weight in kgs divided by height in meters square, right? So this is nothing but again weight for height. So it will also decrease. It will also decrease, right? What about chronic malnutrition? In chronic malnutrition, now for a longer period of time, the child is not receiving enough nutrition. So along with the weight, height will also decrease. So weight decrease, height also decrease. If you take weight for height, height is also less, weight is also less. So it may be normal. It may be normal, right? And same goes for BMI. So this is how you're going to differentiate acute from chronic malnutrition. Now coming to the questions that they ask the exam. What do they ask? They ask, what is the hallmark for chronic malnutrition? In chronic malnutrition, I know my height is going to be affected. So this is the hallmark, right? What about acute malnutrition? Weight for height, weight for height, right? You can see weight for age is same in both, so that can't help me differentiate. But height can help me differentiate in chronic malnutrition. In chronic malnutrition, height for age would be decreased, and weight for height would be a good marker for acute malnutrition. In acute malnutrition, weight for the height would decrease, right? So this completes the section of nutrition and general pediatrics. Now let's cover some images and over the next 1 hour, we'll try to wrap up everything. The PDF, I think I will share with the team and they will, if you have a Telegram group or WhatsApp group, they will share over there, right? I will still prefer that you use the notes that you were already using and try to shorten them out. The aim of this session was just to highlight those points that are frequently asked in the exam so you can revise again and again, right? So we discussed this general nutrition topic coming down to neonatology, coming to the benign conditions that you see in newborn, right? So the first condition, what can you see here? You can see small whitish dots like lesions, right? Small whitish dots like lesion with erythematous base, right? Usually seen over the face, neck. If you take biopsy of these lesions, they are filled with eosinophils. What are these lesions? This is nothing but erythema toxicum, which is a benign condition. We don't need to worry about this condition, a benign condition that is erythema toxicum, right? Moving to the second image, what can you see here? There is a bluish patch over there. Voice is echoing. What to do? The voice is echoing, right? Okay, so clinical topic of neonatology and some images from systemic pediatrics is left. We will resume that tomorrow, right? Just cover these benign images and then we can end at 8 p.m. And just 1 hour session will be left that we cover tomorrow at 9 p.m. Okay, it goes well for us. So let's just cover these images, the benign topics, the benign lesions that we see in newborn. This is the first image, erythema toxicum, right? The first image, erythema toxicum. So what do we see here? So what do we see here in erythema toxicum? There were small whitish spots, erythematous space. If you take biopsy of these lesions, they are filled with eosinophils. Then in the second image, we are seeing this bluish slate colored discoloration of the skin. This is a normal newborn finding. This is known as Mongolian spot. Mongolian spot, right? Now in the next image, you can see bigger pustules, bigger pustules. If you take biopsy of these lesions, they are filled with neutrophils. These are known as pustular melanosis. This is also a benign condition. You don't need to puncture these lesions or do IND of these lesions. You just have to maintain good hygiene, right? Now look at the nose of the baby. Small white spots over the nose, right? This is nothing but sebaceous hyperplasia. Sebaceous hyperplasia, right? Moving to the next image, can you again see pearly white lesions over the face, over the chin of the child? This is nothing but milia. These are nest of the epithelial cells, right? This is epidermal inclusion cysts over the face. If similar epidermal inclusion cyst over the palate is seen, this is Epstein pearls. Epstein pearls, right? And if similar epidermal inclusion cysts are seen on the gums, these are known as Bowen nodules. All of these are benign lesions that are seen in newborns. Then with exposure to cold, this is seen in some babies. Can you see one area of hyperemia where the skin is red, one area which is pale, right? This is due to the abnormal vasomotor response to the cold. This is known as cutis marmorata. Once you warm up the baby, this will disappear. This is again a benign condition of the newborn, right? Now look at this image. What is happening at the finger of this baby? Soon after birth, you notice this lesion. What is this? Actually, in utero, this child was sucking on this finger, right? The child can suck on any of the limbs, and because of that vigorous sucking, a sucking blister can form. This is yet another benign condition, that is sucking blisters. Then we have this half side of other one color, red, other is pale. This is harlequin color change. Harlequin inspired by that Joker character. Harlequin color change. Yet another clinical stain that is asked in your exam. A newborn female presents to you with vaginal bleeding, right? Is this normal or abnormal? This is perfectly normal. This vaginal bleeding is due to the deprivation of maternal hormones. Inside the uterus, what happens? The child is receiving, the baby girl is receiving mother's hormones, right? So uterus lining, it thickens down. And as soon as we separate the baby from the mother, that is, we cut the umbilical cord and cut the source of hormones, this uterine lining will shed, leading to vaginal bleeding, right? This is vaginal bleeding due to deprivation of maternal hormones. Sometimes due to vaginal delivery, babies that are born by vaginal delivery, you can see this. What is this? This is subconjunctival hemorrhage, right? As during the vaginal delivery, the baby is passing through that narrow vaginal canal, the baby is squeezed out of the narrow vaginal canal, there could be some superficial hemorrhage, subconjunctival hemorrhage, sometimes retinal hemorrhages as well, that are self-limiting, nothing to be done about. These are the benign condition. Okay, right? This is a marker of a post-term baby. This is seen in post-term babies. Nothing to be done, just apply, ensure that the baby stays moisturized. Coconut oil, virgin coconut oil could be applied, right? These are the post-term babies feature, right? So these complete the benign conditions that are seen in newborn. Rest of our topics of newborn and certain questions, a 1 hour session is left. We're going to discuss that tomorrow at 9 p.m. And I hope these technical issues would be resolved. Thank you for staying with me. Till then, I think we can end this session now. If you have any doubt regarding this session, just put it down in the comment section on this live session, and I'll try to cover them up tomorrow if possible. Right, we are ending the session today at 8 p.m. The rest 1 hour will be covered tomorrow 9 p.m. Right.